Alright guys, sorry about that. I didn't realize that my on-screen recorder here could only record for up to 15 minutes, so I'll try to keep a better eye on the time for the rest of the videos. Good job, baby. Sorry, my daughter walked in. Alright, so we were talking about sorry guys, bear with me here. Ipratropium. We said that ipratropium is an anticholinergic, means it goes against the parasympathetic nervous system. You could also refer to this as a sympatholytic. It doesn't cause bronchial constriction, but it limits what is causing it doesn't cause bronchial dilation, but it limits what is causing bronchial constriction. It also helps to limit bronchial secretions. So we can give this with albuterol. We don't give this on its own. Contraindications, hypersensitivity. Know that it is an alkaloid solution. Side effects, nausea, vomiting, blurred vision, so on and so forth, very, very similar to that of albuterol. Albuterol, though, doesn't normally cause dry mouth. It may cause some coughing. We didn't talk about that. When we're treating patients with bronchial constriction, especially patients that have a lot of mucus in their lungs as well, so we may hear rhonchi along with the wheezing, then it's very common for these patients to start coughing and their SATs to actually decrease before they get better. And the reason for that is they've got all this thick gunk in their lungs, and when I start to open up the bronchioles to where air can move more freely, it starts to break up some of that stuff and it helps to move it up out of the lungs, and so they are stimulated to cough. Hopefully it's productive cough. This can last several minutes. It could make the patient worse theoretically, but oftentimes the SATs will get a little bit lower. They'll be a little bit more distressed for a brief period of time, and then once they start getting some of this stuff up, then they start to breathe a little easier. Their SATs start to come back up. Okay, so our dose is measured in micrograms for this drug, and this is 500 micrograms. Remember that 500 micrograms is the same as 0.5 milligrams. You can term it either way. Either way would be perfectly fine. We're not giving it for pediatrics right this minute, so just disregard the pediatric dose, and it is a pregnancy category B Bravo. So let's go back to our protocol real quick. Excuse me. And we'll see the epinephrine 1 to 1,000, 0.5 to 0.5 IM is listed on here. We're not going to talk much about that today, and the reason for that is we're not treating anaphylaxis today. And you can consider epi-IM for significant bronchial constriction that is not responsive to other medications, but it is not a frequently used intervention. So today we're going to focus on what is more frequently used. So let's look at magnesium sulfate. I know I'm skipping around a little bit, but there's a reason for that, okay? Magnesium sulfate over the last few years, I'd say, has become much more prevalent as not first line, but maybe second line intervention for bronchial constriction. It used to be one of those things that, hey, this is a really last resort, last ditch effort. I'm going to try some mag before I elect to RSI this patient because they just aren't breathing well and nothing that I'm doing is working. But magnesium sulfate has moved way up towards the forefront, and the reason for that is because it really works. Magnesium sulfate works really well for bronchial constriction. So let's take a look at that on our drug cards. Magnesium sulfate is an electrolyte, and magnesium sulfate in the pre-hospital setting is used for a variety of different things. You're going to see that on the indications there's a whole bunch of stuff that we can consider magnesium sulfate for. Today we are focusing specifically on using magnesium sulfate for the use of bronchial constriction. So its action is a smooth muscle relaxant. That's the big thing we're looking for today. Though it is somewhat of a CNS depressant, it can be used as an anticonvulsant, and an antiarrhythmic. The way that it works as an antiarrhythmic isn't exactly known, but it does have some antiarrhythmic properties. We'll talk more about that when we talk about cardiac arrest management. Onset, IVIO, is immediate. IM 3 to 4 hours. Just know in North Carolina we don't give it IM currently, but IM is an acceptable route, so you may see this done in the hospital. Indications: eclampsia, severe refractory VFib, pulseless VTAC, torsades de pointes, induces uterine relaxation. You can stop labor with magnesium sulfate. Can cause bronchial dilation after beta agonist is what that should say, and anticholinergics have been used. So this is saying that you should use beta agonists and anticholinergics, i.e. albuterol, Atrovent, before you consider the use of magnesium sulfate, and we do normally do that. Again, this is not the first line medication, but it should come pretty close after your albuterol Atrovent for severe respiratory distress. If the patient has a little bit of wheezing, they're an asthma patient, and the albuterol is bringing their SATs up and they're less distressed after one treatment, then we're probably not going to move down the line towards magnesium. But if the initial interventions we provided have not been effective and or the patient isn't getting better, then we're going to absolutely consider adding magnesium to our box of tricks. Contraindications: shock, hypotension. So this is very important. We said a few minutes ago that magnesium sulfate is a smooth muscle relaxant. That's right here, smooth muscle relaxant. That also means that it dilates blood vessels. So the patient is already in shock, even if they're in compensated shock, then this can cause the blood vessels to dilate, which can cause the blood pressure to get really low. So patients who are already hypotensive or who are in shock, we do not want to utilize magnesium sulfate for them. All right, our adult dose. This is subjective to an extent depending on what it is we're treating. Remember that we have a almost endless list up here for indications for magnesium sulfate. For bronchial constriction, and bronchial constriction only, our dose is 2 milligrams over 10 to 20 minutes. 10 milligrams IVIO over 10 to 20 minutes. An easy way to do this is put your 2 milligrams in a 100 milliliter or 250 milliliter bag of saline or D5 or whatever it is you're electing to use this day, and set it on your pump for 10 to 20 minutes. It's really subjective. It lets you do 10 to 20, so it doesn't have to be an exact science. Just anywhere between that 10 and 20 minute mark, you're good to go. I like a 250 bag run almost wide open, but not quite wide open, because it runs in almost every time in about 10 to 15 minutes. So it's a lot easier to keep an eye on. All right, so let's go back to our protocol here real quick. And the reason that I went to magnesium before methylprednisolone is because you'll see that methylprednisolone doesn't have a super warranted use in the pre-hospital setting. And what I mean by that is we give it all the time, but let's see if I can find it here. We are not going to see the effects in most situations from methylprednisolone. And the reason for that is methylprednisolone's onset is 1 to 2 hours. Now, why do we give it then if it's not going to benefit the patient while we have them? We give it because it's going to benefit the patient in 1 to 2 hours. And bronchial constriction normally is not something that, oh, I've got a little bit of respiratory issue going on, I'm going to take a medicine that's going to fix it, and I'm not going to have to worry about it, for the next week or whatever. Most often, even with bronchial asthma, this is a recurrent issue. Patients with chronic bronchial constriction, COPD patients, asthma patients, they normally take some type of inhaled corticosteroid. I think I've already said that, like the Advair disc, and oftentimes that's a powder that's inhaled, and it works in a very similar way to methylprednisolone. The trade name of methylprednisolone is Solumedrol. You've probably heard that term before, but the generic is methylprednisolone. Again, it's a corticosteroid, and we use it for bronchial constriction. We do give it. It's kind of a standard after your albuterol Atrovent, so albuterol Atrovent, Solumedrol, and then MAG if you need it. But the Solumedrol is to help the patient in a couple of hours from now. We are probably not going to see the effects of Solumedrol in the back of our truck. Know that anything that, or any type of steroids can cause issues with blood sugar, so just keep that in mind. Our dosage for bronchial spasm is 125 milligrams IV. 125 milligrams IV. Our protocol allows us IV, IO, IM. So I'll go back and add that. I thought it was IM, but I wanted to make sure. IV, IO, IM. Pregnancy category C, which means that, of course, if the benefits outweigh the risk. In this case, since it's not an emergency treatment, I would say the benefits probably don't outweigh the risks. Okay, so if your patient is pregnant, probably don't give this. Now, another thing it talks about on your drug card is a spinal cord injury, and that is something that we have historically used Solumedrol for in the pre-hospital setting. It is currently not in protocol in North Carolina to administer Solumedrol for spinal cord injuries. Okay, I've left it on here because it is something that you may need to know, but it's not something that we routinely do in the state of North Carolina. Along the same lines, before we go back to our protocol, another drug that you can consider that is a corticosteroid is called dexamethasone. Trade name of that is Decadron. So Decadron is trade name. Dexamethasone is going to be the generic name. It also is a corticosteroid. It acts in a very, very similar manner to that of methylprednisolone. Oftentimes we give... Sorry, my computer messed up there. Here we go. All right, oftentimes we give Decadron in pediatric patients because we can give Decadron PO. Now that sounds weird. First, Decadron is drawn up out of a vial just like your methylprednisolone or Benadryl or any other medicine is. So we're drawing this up out of a vial, and I can squirt this in the patient's mouth. I can't imagine that it tastes very good, but it is an acceptable route of administration. And so this prevents, in some situations, you having to start an IV or give an injection to a child. So we do use this in children. From what I've seen, at least more than we use it in adults, but in a hospital setting it is used in adults as well. Your state protocol does not have a dose for dexamethasone. Most common dose I have seen administered is 10 to 40 milligrams. We can do it IV, IO, we can also do it PO. Alright, back to our protocol real quick. Excuse me. I'm going to scroll down here to our pearls. Now we are at our pearls. Let's look at a couple of things just as a review. All right, patients may receive more than 3 nebulizer treatments and should continue until improvement. Now, that is for your albuterol nebulizer. The next statement talks specifically about your Atrovent. Following 3 combination nebulizers. So when we put albuterol and Atrovent in the same nebulizer together, we call that a combivent, we call that a duo neb. There's lots of different names for it, but it just means we've combined those 2 meds together. Following 3 combination nebulizers, it is acceptable to continue albuterol solely with subsequent treatments, as there is no proven benefit to continual use of ipratropium. Ipratropium is a good drug. It works really well, but after about 3 doses, then there is no evidence to support its continued use because it's already, having the effect that it's going to have. Epinephrine. All right, allergic reaction or anaphylaxis is suspected. This should be our first line drug in addition to oxygen, obviously. Okay. Again, we're not talking about allergic reaction specifically today. There's another day for that. So we're not going to get too much into that. However, we are going to go back and we're going to look at another form of epinephrine because we can administer epinephrine as an inhaled medication. Excuse me. Scroll back up here a little bit. Epinephrine nebulized. Alright, so we know about epinephrine already. We've talked about it a lot over the past few months, but just as a quick review, epinephrine is a sympathomimetic, which means, again, it simulates the effects of the sympathetic nervous system. Epinephrine, as it occurs naturally, is an endogenous catecholamine. When we administer it via the IV route or IM or inhaled or whatever it is we're going to do, it's considered an exogenous synthetic catecholamine. But we know that epinephrine has effects on both alpha and beta receptors, but we know that the affinity of epinephrine is much higher to beta receptors than alpha receptors. So that means that primarily the effects of epinephrine are going to be that of increased heart rate, increased inotropy, which means the strength of cardiac contraction, increased speed of electrical impulse through the heart, and it also means that the bronchioles are going to dilate. We're not going to get as much vasoconstriction with the epinephrine as we would with, say, norepinephrine or Levophed. So the onset when we're using epinephrine nebulized is immediate. All right, when we suck something into the lungs, it's a fairly immediate onset. Indications: severe allergic reactions, bronchial asthma, refractory to other interventions. This is what we're focusing on today. Bronchial asthma, refractory to other interventions. I've told you this word refractory before I wrote it on the board, and that word refractory means I've done this other stuff and it's not helping, so we need to consider another intervention. Excuse me. Contraindications: obviously hypersensitivity, hypertension, severe tachycardia, tachyarrhythmias, caution in patients with cardiovascular disease. That means patients who have pre-existing heart issues. I may want to reconsider the use of epinephrine. This is not like albuterol. Remember, with albuterol we said, hey, the heart rate's high, that's probably okay as long as they're not in SVT or VTAC or something like that. It's a little bit different with epi because epi is so much more potent. It's going to increase the heart rate substantially. It's going to increase the workload of the heart substantially. There are absolute benefits, and those benefits may outweigh the risks, but in patients with pre-existing cardiovascular vascular disease patient, we may want to consider something else. Side effects, very similar to that of albuterol. All right, dosage and route. Adult, 1 milligram. So this is how we're going to mix it, okay? We're giving 1 milligram of Epi 1 to 1,000. Very important that you know how to mix this. 1 milligram of Epi 1 to 1,000 in 2 milliliters of normal saline. So what you're going to do is you're going to take your 1 to 1, your little glass ampule of Epi 1 to 1, and you're going to break it open.